Welcome everyone to this traffic safety webinar sponsored by the North Carolina Governor's Highway Safety Program. This is one in a series of webinars addressing topics of interest for traffic safety professionals. The series is co-hosted by the Institute for Transportation Research and Education at NC State University and the University of North Carolina Highway Safety Research Center. Today's topic is medical conditions which mimic impairment, presented by Lieutenant Eric Sweden with the City of Raleigh, North Carolina Police Department. It's my pleasure to welcome Sarah Garner with the North Carolina Conference of District Attorneys, who will introduce Eric. Sarah?
Thank you, Gene. Good afternoon, everyone. It is my pleasure to introduce Eric Sweden to you. Eric has been a officer with the town of Raleigh since 2000, which is quite some time ago. He does routinely teach throughout the southeastern United States and beyond on traffic safety and other issues, not only for the Raleigh Police Department, but also with us at the Conference of District Attorneys and with the community college system. Eric has been qualified and testified as an expert in the district and superior courts here in North Carolina on collision reconstruction, impaired driving, and other topics. He is a DRE instructor, an SFST instructor, and also, more particularly for this presentation, is credentialed as a paramedic and has taught EMS programs throughout the state. So one of the things that we all know as prosecutors and law enforcement officers, you also know because you've had to deal with this in court, one of the ways that folks defend impaired driving cases by saying, oh no, I'm not impaired, I'm just sick. And sometimes folks actually are sick, but the good thing about the way that officers are trained as far as DWI investigation is to ferret out whether it's a true illness or a feigned illness. And Eric is going to share with us some of the things that you need to look for, things that you need to know, and ways to fend off these defenses before a defendant realizes that perhaps this will work long after the time of arrest. So with that, Eric, it's all you.
All right, can you see my screen?
Yes, sir.
All right, we're good to go. All right, so we're going to talk just about an hour now about medical conditions that mimic impairment. And my opinion is there are none. And you'll see what I'm talking about here in just a second. So first, with any government presentation, I need to give a disclaimer. Attendance at this presentation does not qualify you to perform surgery, diagnose serious medical conditions, dispense any type of medication, take any medication for which you are not prescribed, or tell good jokes. Please leave that to professionals. And now on to what we're talking about. Impairment. Is it alcohol, drugs, or a medical condition? And this is the decision that you need to make once all the information has been gotten by you, usually roadside. Sometimes right at the driver's window, you're going to suspect something as long as we're paying attention. So we're going to look for impairment. And then is the impairment due to alcohol, drugs, a combination of drugs, or is it really a medical condition? And this is what we're looking at for the North Carolina DWI statute. You all know what this is, and nowhere in here does it say it is it's against the law to drive while having a medical condition, diabetes, hypertension, maybe some type of seizure disorder, unless obviously you're having the seizure at the time. Even still, that's a medical condition. None of this is DWI based on the North Carolina statute. So let's get something out of the way first. The body will not self-produce an alcohol result of 0.08 grams of alcohol or higher. It will also not result in your testing positive for heroin. Your body does not make these things. Once it starts doing that, we'll have a different conversation. However, the body under the right conditions might produce alcohol. And it's been found that Asian females who have a high carb meal on board with GI ailments and genetic predisposition may produce alcohol. The occurrence is somewhere between the range of 1 in 6 million, and the alcohol concentration is seen in the range of 0.001. So let's put that out there. The body did not produce the results that you are finding. So let's go back to reality and talk about impairment, because that's what it is. Impairment is impairment, and medical conditions are medical conditions. We don't need to confuse the two, because it's really not that difficult. Now, why are we here? Well, there are medical conditions that have some signs and symptoms that are consistent with impairment. We've seen this, we've talked about this, but we're not going to surrender common sense and reason when we can explain things away. I do appreciate that everybody who came here is in the front row. You're all sitting in the front, and I appreciate that. Tim, nice shirt. I can see you right there. Here's my question. Has anybody had a headache? Has anybody felt tired? Has anybody been confused at some point in their life? Well, if you've had the headache, did you go to the hospital? If you felt confused, did you go to the hospital? Or maybe did you have a headache for some other reason? This is what people are doing, is they're surrendering common sense and reason. And your arrest, the officer's arrest, is based on the totality of the circumstances, all the information that you have gathered and can gather. And we'll talk about some things that you can do to make sure that we don't arrest somebody who is actually having maybe a diabetic crisis or some other type of medical condition. So what steps do we take to differentiate the medical conditions from impairment? So let's take a look at some conditions we may have known about, heard about, talked about in the past. Diabetes is a big one. A lot of folks want us to believe that we are confusing impaired drivers for diabetics, or diabetics for impaired drivers, and that's just not the case. You'll see that here. Hypoxia, a head injury, strokes, traumatic brain injuries, hyper and hypothermia, post-traumatic stress disorders, MS, and a seizure disorder. Those are common. Those are common ailments out in the public, and none of these people are we arresting for impaired driving. Now, can they have a medical condition and be driving? Sure they can, and we're going to give them the help that they need. Let's talk about the most common one first, and that's diabetes. So when we look at type 1 diabetes, that's the body's failure to produce insulin. Type 2 diabetes is the cell's failure to use that insulin properly. And you don't need to worry about if it's type 1 or type 2 diabetes. You'll see that in here in a second. The other type of diabetes that's out there that's common is gestational diabetes. You'll probably figure that out pretty quickly. All right, pregnant women who develop high blood sugar, that's gestational diabetes. So let's look at hyperglycemia. Now we're going to have two types of diabetics, one with a high blood sugar, and that's this hyperglycemia. And hyperglycemia is usually seen in people who have blood sugars, say, over 200. It's usually a lot over 200. Your normal blood sugars should range somewhere between 80 and 120 when you go to the doctor. That's going to be normal. To get up to 200, to get higher than 200, we're talking about hyperglycemia. These people will present with a dry mouth, extreme thirst, weakness. The higher the sugar level in their body, that fruity breath. So we've talked about that fruity breath, sometimes confused with impairment. And I don't know that I've ever encountered the alcohol impaired driver with a fruity breath. Nasty maybe, but not fruity. And then nausea and vomiting. Nausea, they'll tell you vomiting, well, you'll pick up on that pretty quick. And then maybe deep, rapid breathing, but that's going to be in a crisis state. Let's look for a second at hypoglycemia, which is just the opposite. That's going to be your low blood sugar. So somebody with, let's say, a blood sugar less than 70, arresting, fasting blood sugar 70 and lower, potentially hypoglycemia. You'll see the sweating, rapid heart rate, the decreased coordination. The lower the sugar gets, the more difficulty, the more confusion they will have. So when you get these folks and maybe their sugar is 50, 40, 30, they'll be combative, they'll be restless, headaches, blurred vision, trouble performing routine tasks. Now, out of these signs and some of these symptoms, are any of them related to impaired driving? Sure, we can see some of these in our typical impaired driver. However, they don't need to go with you. They're probably in need of EMS or hospital. In crisis, they're going to have this slurred speech. Okay, that's consistent with maybe our impaired driver. Unsteady on their feet. Okay, that's consistent maybe with an impaired driver. Anxiety, confusion, combative, cold, clammy skin, unconscious. They'll probably have a problem with some of your psychophysical tests. And I don't mean to be funny, but it's really in your face that this is something else that we're going to look at. Go back here. Where's that fruity breath? Where is your weakness, decreased coordination, difficulty concentrating? You're going to exhibit this in your psychophysical tests. So we are going to absolutely take a look at this and take it a step farther. We're going to ask questions. We're going to take a look what's in the car. If you see some of these things, maybe a pump, some of your more brittle diabetics will have an insulin pump, and that's going to regulate their insulin. In the bottom right-hand corner is a gauge where a lot of these folks will test their own blood sugar. You might also find a log somewhere in the car where these folks who have been diagnosed as a diabetic are going to take their blood sugar, sometimes several times a day, and keep track of that. You'll see that in the car. Ask questions. Maybe some of your insulins you'll see in the car. So in the upper left-hand corner, you might see a tuberculin syringe. You might see some of that insulin. So let's take a look and let's ask those questions that we know are going to come up. Law enforcement training, and right in BLET, the basic law enforcement training that all the law enforcement officers attend, it says that the fruity or acetone smell is confused for that drunk driver. Well, that fruity acetone smell is in your hyperglycemic patients. It's the ketones from the sugars. We're not confusing that person because if you remember from 3 or 4 slides ago, those signs and symptoms are not characteristics with your typical alcohol impaired driver. They're actually just the opposite. And then confusion for the drunk driver actually comes with your hypoglycemic people. Now, somebody who's hypoglycemic, so their blood sugar is 40, 30, is not uncommon in people in crisis. And this is probably where you'll come upon that driver with confusion because it comes on quickly. Hyperglycemia comes on over time. Hypoglycemia comes on fairly quickly. And the more you ask them to do, the more tasks that you have them do, their psychophysical tests, they're using energy. They're burning sugars for that energy. So that low blood sugar is going down even farther. The treatment for that, obviously, if they have some candy in the car, that is your sugars that you'll want to get to bring their blood sugar back up. And then when in doubt, usually the best thing to do is give sugar because there's a huge difference between somebody with a blood sugar of 30, 50 to 70 and giving candies, giving low sugars to somebody at 200, 300, 400 is not going to hurt their condition. Both of them need EMS. We'll talk about how we can use them, EMS and the emergency departments, to our advantage here in just a little bit. Hypoxia, I highly recommend breathing. 12 to 20 times a minute is probably good for you. You make good decisions when your brain has oxygen. So the lack of oxygen to the body, or in our case, the lack of oxygen to the brain is hypoxia, right? So your oxygen is displaced, and guess what? We're not thinking well. Strokes, somebody who has a stroke, Somebody in shock, somebody with a heart attack is probably not regulating oxygen very well. Smoke, carbon monoxide. Carbon monoxide replaces oxygen in the red blood cells. So when we displace oxygen somewhere in the body, somewhere in the brain, it will manifest very similar to our impaired drivers. You'll see restlessness. You'll see some confusion and altered mental status. Skin color changes, blues and grays. Blue is a bad sign. So when you see blue around the lips, the nail beds, when you go hands-on and they're cold, you push on their hands and they lose color. And you can do it now if you pinch the tip of your finger, it turns, like a whitish, and then you let go, the blood returns. That should happen fairly quickly. These are all signs of hypoxia. That person needs medical treatment. And we know they need medical treatment. So EMS is actually a good person to call at that point. Your head injuries, strokes. A stroke is a head injury. Be it what the cause, a stroke is a head injury. It is damage to the brain tissue, and this needs rapid treatment. You see the signs in the highways. There's a big push by the American Heart Association and others to recognize strokes quickly. Back 30 years ago, pretty much damage as a result of a stroke was permanent damage. And now early recognition of something like that can actually save that tissue, can save that person's quality of life. For a traumatic head injury, that's, folks, you just need to keep your eyes open. Is it an open or a closed trauma? Closed head trauma sometimes could be difficult to see. You might not see what's going on, and that pressure that builds up inside the head because of a traumatic event causes swelling. So your brain is a closed cavity, and when you have some type of trauma to the brain that causes bleeding, there's nowhere for that to go, and that pressure is life altering. Blunt force trauma, maybe an open injury, it's still bad. You're going to be able to see that, but it actually allows the release of some pressure and gives y'all some time, or the doctors some time, to fix that. So how do I know there's some type of head injury? Well, is there bleeding? Is there swelling? A lot of folks like to talk about bruising. In collision investigation, we talk about seatbelt marks and bruising. Bruising is a late sign of internal bleeding. It takes a little bit of time for that to come up. Look for that swelling, look for that bleeding. Confusion and altered mental status. If you have a mental status change, is that consistent with signs of impairment? Sure it is. Inability to speak, is that consistent with impairment? Sure it is. A facial droop, is that consistent with impairment? Well, no, it sure isn't. If you have one side of the body that has change versus the other side of the body, you have something going on in the brain that's causing it. So a left-sided deficit versus a right-sided deficit, you're going to look to the brain for that, and that's not normal. So if you see that facial droop, one of the quick questions is, hey, what's going on? Is this normal then? Probably not. Are there certain processes that will cause that facial droop and no other single-sided deficit? Sure, there are medical conditions that can cause that. And then your head injuries, your serious head injuries may create unequal pupil size. That's going to be pretty easy when you look at somebody and you see two different size pupils. You're going to know it immediately. It's going to stand out. It doesn't take any special skill or ability to see different size pupils. You don't need to be an eye doctor or a medical professional to see one thing is different than the other. Those are your head injuries. Let's take a look at body temperatures. We see this every once in a while. This was a topic of conversation back not too long ago about impairment due to body temperature changes. And then you have hyperthermia. Hyperthermia is an increase in the core body temperature. And hypothermia is really an umbrella term. It's just that term for your body's inability to regulate the body temperature, the regulation system at that environment. So there's a host of things that can cause this. Hypothermia is just the opposite. It's that decreased core temperature. And usually exposure to cold, and then add water. Anytime you add water, you're going to increase the body temperature change. So if you add water to hypothermia, you're going to get colder faster. When we look at hyperthermia, so right now we're looking at a core body temperature of 98.6 degrees Fahrenheit. The DRE process is plus or minus 1 degree, but we haven't looked at body temperature changes in at least the normal or average body temperature changes. We haven't looked at those numbers in hundreds of years, and that's a problem because as humans, we have become more sedentary. So that's changed actually what that core body temperature is going to be. But we're looking at 104 degrees for hyperthermia, 104 degrees. You're going to know that. Your body's going to tell you, hey, Eric, there's something wrong here. And for hypothermia, you're looking at about 95 degrees Fahrenheit and lower for hypothermia. Your body is going to change that. Your body wants to maintain what we call homeostasis. Homeostasis is the body's ability to maintain normalcy. Some things are consistent, especially when you're talking about body temperatures. Hyperthermia, the higher your body gets, could create shaking, seizures to release that heat. In hypothermia, in your low core body temperature, your body can also do the same thing, is create that seizure to generate heat. So sometimes these can be difficult to treat overall. But again, that's for EMS in the hospitals to take care of. Usually a result of environmental exposures, although there are certain drugs that can increase your core body temperature artificially. So regardless of the outside temperature, there are drugs that you can put into your body that will increase that core body temperature, and drugs that will decrease that core body temperature. One thing to note here is neither of these body temperatures, hypo or hyperthermia, neither have an effect on HGN. And that's really important to note, because once you get somebody out and it's 90 something degrees here in Raleigh, no HGN is you're not going to have an effect. Maybe it's January here and it's 30 degrees, still no effect on HGN. When we talk about temperature changes and eye movements, some folks have heard of a process where you get a temperature change at the inner ear, and that's where the change needs to be to have an effect on the eyes. But none of these things will affect the HGN. The officers need to feel comfortable with that. Some exposures for heat and cold is an altered mental status, drowsiness, confusion, unsteady. See, all consistent by itself, maybe with impairment, and then dilated pupils. Once you start looking at dehydration and hyperthermia, now those conditions put together can manifest pretty much like a stroke. So once you take away the fluids of the body, you increase a core body temperature, you start affecting the body chemistry, this can manifest absolutely as a stroke. So these medical conditions, when placed together, are sometimes difficult to diagnose. Let's move into seizures for just a minute. Not this kind of seizure. This kind of seizure. So what causes a seizure? Well, there's a lot of things that can cause a seizure. Some people can be predisposed to it. So epilepsy. Epilepsy is clinically diagnosed and it happens in the brain. Any seizure actually happens in the brain. I'll show you this in just a second. Happens in the brain. So high blood sugar or low blood sugar could cause the body to have a seizure. Increased core body temperature, decreased core body temperature also can cause the body to have a seizure. Some type of brain injury, a closed head injury, including strokes, could induce seizures, and also drug use, and more so in overdose settings, can create a seizure. This is what I mean about a seizure. The seizure actually occurs in the brain. That top picture is normal conduction within the brain. That's the way it's supposed to. When you, in the bottom, change that, you can create that seizure. So that seizure disorder in the brain, how do you know what's happening? Because you can't see it in the brain. Well, it manifests itself in the body. So that's where we're looking. When you see, and what we're used to maybe is from television, a full tonic-clonic, full body seizure versus maybe some petite seizures. Sometimes you just see it in the eye, you'll just see the fluttering. It could happen in a hand. Those are seizures. The seizure actually is occurring in the brain. It's manifesting itself in the body. So we need to pay attention for that and treat that accordingly if you see it. Indications of a seizure, they're unsteady on their feet. Again, is this consistent with impaired driving? Sure it is. That aura. There are some people who can feel the seizure come on. They will actually tell you, officer, I'm getting ready to have a seizure. Now, this is a decision you're going to have to make if you have already gone hands-on, put this person in handcuffs. What are you going to do with that? Because as these seizures manifest itself in the body and they have those full muscle movements, the muscles in the body contract and expand. They do it together, right? So as my arms come out, I'm going to pull in and push out together. This doesn't happen in a seizure. This is not a thing. So when you have this, right, or you see those muscle groups working in concert together, that's the seizure. So think about that when you're having somebody in handcuffs and they look at you and they say, officer, I have a seizure disorder. I'm getting ready to have a seizure. It's not a lie. They do feel that come on. Confusion, consistent with an impaired driver? Sure, could be. Blank stare, consistent with an impaired driver? Could be. Same thing with dilated pupils. The uncontrolled muscle spasms? No, right? That's going to be your seizure activity. MS, so multiple sclerosis. I don't know if anybody knows anybody with this, but this is a very debilitating disease process. An inflammation where the myelin sheaths around the axons for the brain and the spinal cord get damaged. And this is really intense. I've had a lot of firsthand experience with this. I actually had a rookie, a new officer, who was diagnosed while he was with me with MS, and that disease for him progressed quickly. And you can see it in his ability to do normal everyday activities. When they present sometimes with anxiety, balance disruption, depression, dizziness, speech difficulties, tremors, and some mobility issues. So what is their gait when they get out of the car? How do they walk? A lot of people, if they have a disease process where they believe they could be confused with an impaired driver, they're going to tell you. They're absolutely going to tell you because what do they have to lose? It could be their license, but at least it won't be their freedom. However, let's take a look at something. A lot of these medical conditions do have medicines that will suppress signs and symptoms. Sometimes the disease process isn't the impairing substance. What it is the medications that they are taking for the disease process. So when you take a look at this list of medications, which not all people with MS are taking all of these medications. That's not what I'm saying, but these are medications which are common to be taken with MS. A lot of times it's just to bring them back to normal. Valium, Xanax, Klonopin, Paxil, you've heard of these, Prozac, Ativan, a lot of your serotonin, norepinephrine reuptake inhibitors, your SNRIs. You see this on television. You see Cymbalta and Wellbutrin, your tricyclic antidepressants. Elavil is a real hardcore medicine, and when taken outside of its normal dose, actually could be fatal. Zofran, Dilantin, and Dramamine, all of these are impairing drugs by themselves. Now, when they're taken as prescribed, all of these medications do what they're supposed to do. Here's the issue with a lot of folks who have different medical conditions. I have anxiety, so I see one doctor who prescribes drug A. I have depression, I see another doctor who prescribes drug B, and I've got some low back pain because I've been wearing a belt with 13 pairs of handcuffs in the back, and he prescribes me some muscle relaxer and maybe a pain med because I'm a really nice guy. None of these doctors know each other, but all of these doctors have prescribed me medicine, which if I take outside of its usefulness can cause impairment. However, when I start to mix these medicines, because Dr. A, Dr. B, and Dr. C don't know each other, that's where my impairing effects start. So now I go from being normalized with my medications taken as prescribed by my doctor to impaired because I'm taking multiple drugs. And actually, when we look at the DRE program, we're taking multiple drug categories a lot of times. And that's where you could see your impairment, your drug impairment in medical conditions. So while I tell you that I don't think there's a medical condition that mimics impairment, that impairment is impairment, we need to look at all of this. We need to take a look and say, all right, this medication is being taken, it's used as prescribed, but in combination with this other one, now I have an impairing effect. So just because I have this disease process and this disease process doesn't make me impaired. However, the medicines that I'm taking for each one, those are the drugs that impair me. So how do we determine if it's impairment or a medical condition? We know we've got medical conditions. We know just because I have a headache doesn't mean I'm having a stroke and I don't need to go to the hospital. Just because I have slurred speech doesn't mean I'm having a stroke. I could still have impairment. So how do I mirror the two and make good decisions? Well, I'm going to stay at a Holiday Inn Express. That's what got me this far, and I'm just going to keep doing it. Plus, I get good points, and I'm going to think tactically. You three guys in the front row just heard the word tactical and you woke up, so thank you for that. So let's take a look. First is your driving history. We need to take all of the information that we have learned as law enforcement and put it all together. What is that phase one? What is vehicle in motion? What did I see? How is this consistent with impaired driving? Sometimes we don't have it. Sometimes you took and you stopped the car for a dead tag and you have no bad driving. Well, what's good for us is you don't need to prove that. You don't need bad driving, right? I mean, you do need to prove the guy was driving. Let's just put that out there. But you don't need to prove bad driving. What is your phase one? Because phase one got you to phase two. And phase 2 is that personal contact. As you approach the car, what's inside? Remember those pill bottles? Remember that tuberculin syringe, right? We're cops. We like to look at that tuberculin syringe and go, you're on heroin. Well, no, maybe that's his insulin. Okay, but that's still your personal contact. Some folks don't like to ask this question, but I do. I really need to ask this question because I do not like to arrest people who really need an emergency department. Do you have any medical issues or physical injuries? When they turn and they're like, nope, I'm like, okay, we're good here. We're still going to rule some things out because yes, confusion. Well, confusion doesn't give the wrong answer. Confusion is what? I don't know. What does the number yellow smell like? I don't know. All right. So do you have any medical issues or physical injuries? I don't see anything. I'm pulling out of the car and we're doing phase 3, my pre-arrest screening. This is where we are going to differentiate a lot of medical conditions from impairment. HGN, walk and turn, one leg stand. And based on those tests, we're going to make a decision roadside whether this person is impaired, whether the impairment is due to alcohol, drugs, or a medical condition. And this brings us full circle where we were. Let's take a look at how. So the truth is in the eyes. Hopefully, most of you have been through standardized field sobriety test class. If not, I highly recommend standardized field sobriety tests so that you can get a little bit more information on how all these things work. What is that medical condition? What are these tests? How valid are they? Are they validated? Does it work? All right. So when we look at the eyes, is there resting nystagmus? Is this a medical condition? Is this impairment? Let's look at equal pupil size. What if they're not? Well, the only way you're going to figure out if this is normal for them is to ask. We're cops, we're inquisitive, we ask some things, and Sarah will tell you sometimes we ask things that aren't exactly appropriate. But hey, Phil, is this eye and this eye, they're different sizes. Any reason for that? Maybe there is, and then we're going to rock on with some answers. So what do I see? What do I hear? What do I smell? Right? What do I feel? Are there pill bottles in the car? Take a look. Are there pill bottles in their pockets? You're going to notice that. You don't need to pat somebody down or to search them. A lot of times you're going to see it. If they come out with, like we talked about, that aura phase of somebody who's predisposed to seizures, I'm about to have a seizure, officer, probably going to believe them. More times than not, I'm going to believe them, and then wait for those muscle groups working in concert, and then again calling EMS. Is there an odor of alcohol? We talked right off the bat about the body not producing alcohol inside. That's not a thing, so don't surrender common sense and reason for that. If you get to the point that you're making a full custody arrest, you're getting more information as soon as you go hands-on, because now you see, is that muscle tone, is it flaccid or is it rigid? And when we go into A-RIDE, so for all of you who have been SFST trained, I would highly suggest going to A-RIDE, Advanced Roadside Impaired Driving Enforcement. Gives you just a little bit more information. What happens when this impaired driver doesn't have an odor of alcohol? What happens when they do blow double zeros into your PPT? Now what? That's a whole lot of information that's going to differentiate some medical conditions and some drug categories. And how about their skin? When you go hands-on and you touch their skin, is it abnormally hot? Is it abnormally cold? Is it wet? All right. Usually wet skin is a sign. Well, it could be a couple of things, but if you're putting your hands on them, maybe that core body temperature is just jacked way up and you're looking at 101, 102, 103, right? So could this be hyperthermia? Sure it can, but you just took them out of an air-conditioned car at 78 degrees chances are it's some drug working on the body causing that core body temperature to increase. When in doubt, if you ever have a thought in your brain that this is not impairment due to alcohol or drugs, let's call EMS. Let's call paramedics. They live for this. That's what they do. This is their job. This is their life. Ask people. More people would tell you that they have diabetes or a seizure disorder. I got it. We're all private people. But if it's the difference between me going to jail because you think I'm impaired on drugs versus my diabetes, I'm going to tell you. Unconscious people, that's straight up EMS. Look for medical alert bracelets. It's not really vogue. You know, the little heart with the star of life inside doesn't match my blue shirt, and the bracelet just doesn't go with my pumps. I got that. Let's take a look around. EMS can be your best friend when they show up. They can rule out a bunch of medical issues right on scene. They have those tools to do that. Let them make the decision at that point. If you are not 100% comfortable in your arrest as to whether this is a medical condition or impairment, let EMS help you out. Their information will be crucial. Those are just some of the medical conditions that mimic impairment. There's a lot of medical conditions out there. There's a lot of medications out there. But when we do our job and we do it in a systematic and standardized method, and we use known principles and we rely on common sense and reason, you're going to be able to differentiate your impaired driving arrest from a medical condition. And with that, I will answer any questions if you have some.
Eric, thank you so much for a great presentation. A lot of terrific detail in that. So definitely want to invite folks to ask Eric any questions you have about the topic today. Reminder, a couple of ways you can do that. You can first raise your hand, and we'll open your mic, and you can ask and talk directly with Eric, or open up the Q&A window and type in your questions or comments. And Eric, while we're waiting for some initial questions to come in, let me ask you a couple of follow-up, if I may. First of all, are there any medical conditions which would affect the clues found in the SFST test?
So yes, when you look at some of the disease process which could cause somebody to be unsteady on their feet anyways, you could manifest that in a walk and turn. They might not be able to do the walk and turn. Same thing with their balance. If they have some type of inner ear disorder or vertigo, they might not be able to do the one leg stand. They might not just be able to keep their balance because of their medical conditions. So yeah, it can manifest in the standardized field sobriety tests. And that's one of the things that we're going to have to make a decision at the end of the enforcement.
Okay, thank you, Eric. Another follow-up question: if you call EMS or the driver goes to the hospital, is your DWI investigation over at that point?
So no, actually, you can use the information from EMS or the hospital if they get that far to help continue your investigation. So, for example, the argument is the driver is a diabetic. If I employ EMS or they go to the hospital, well, EMS and the hospital are going to draw blood sugar. So I'm going to figure out real quick with the help of the paramedics, is this blood sugar somewhere between 80 and 120, which is my norm, or is it outside? So actually, the information that the paramedics can get you roadside or the hospital can get to include blood pressures and pulses and respiratory rate, can help you differentiate that medical condition, but can also help you if your impairing substance is a drug. So they could be a very valuable tool to you. So your investigation is not over once they show up.
Very good. Thank you. I'm going to stop your screen sharing for a minute. And we actually do have a question come in here in Q&A. The question, Eric, is how do eyelid tremors from cannabis compare to seizures? Do they look similar?
No. So your eyelids are smooth muscle. And the seizures that we're talking about are full-blown motor function. So could you have a seizure type activity in there? You probably could, but I think when you look at the eyelid tremors based on cannabis, you're going to see something that's not even. I don't know that I would hang my hat on an impaired driver because of eyelid tremors, but it's going to look different.
Okay, thank you, Eric. And again, just a reminder, if you've got a question or comment, feel free to just raise your hand, call on you that way, or as we just saying, you can type it into Q&A. Again, while we're waiting for some additional questions to come in, I had one more follow-up for you, Eric. You mentioned that both hypothermia and hyperthermia do not affect HGN. Are there other medical conditions that may cause HGN? And in addition to that, for those who are attending today who aren't familiar with HGN, could you actually start by maybe explaining what that is?
Sure. HGN is horizontal gaze nystagmus. Horizontal gaze nystagmus is that involuntary jerking of the eye as it moves to the side. And that is consistent in alcohol impaired drivers, and then some categories of drugs will induce HGN. Now, nystagmus comes in all shapes and sizes. There's 42, 45, something different types. The only thing we're looking for in impairment is horizontal gaze nystagmus. And the only thing that's going to cause horizontal gaze nystagmus is alcohol and certain types of drugs. So the question was, will you see HGN in other medical conditions? You're not going to see HGN in a medical condition. You can see types of nystagmus possibly, but nothing that's going to be consistent with the horizontal gaze nystagmus we're looking for during impaired driving investigations.
All right.
Eugene,
Yes.
This is Sarah. I've got a question. Eric,
Go ahead.
what are your thoughts about if in fact you do stop somebody and it turns out that it truly is a medical condition? What are your thoughts about officers doing the paperwork for a medical review for a medical revocation of a driver's license? Is that something you think should be done?
So absolutely, and I really should have addressed it in here. Just because you're not arresting them for the DWI doesn't mean that they're safe to operate vehicles. So if you have somebody that you are taking out of a vehicle, be it a traffic stop or a collision, and say you do find out that the impairment that you're seeing is related to a medical condition, I highly encourage everybody to fill out that driver re-examination form. If I'm a brittle diabetic and I'm out there and I'm driving and you stop me and you say, you know what, he's not impaired by statute, but this medical condition makes you a dangerous driver, absolutely fill out that medical reevaluation form. I encourage officers to see what on there is a factor. What can I put on here? But absolutely use that tool, have them reevaluated by a doctor before you allow them to go out on the roads and injure or kill themselves or somebody else.
And that form is available on the internet because I looked it up myself.
Sarah, thanks for that question. Do you have any follow-up question, Sarah?
Well, the other question I would have is, Eric, what would you suggest for folks that, because what we tend to see in the courtroom is people that their medical condition is something, I'm not necessarily saying it's contrived, but all of a sudden it becomes much more important to them once they have been charged and made their first appearance in court. Perhaps, I'm not saying that a defense attorney would suggest that they have a medical condition, but sometimes medical conditions do tend to crop up as defenses. What do you think is the best thing for officers to do to prepare their case and prosecutors to prepare their case if somebody all of a sudden is like ravaged with diabetes that they did not mention roadside?
And that's why I like asking the question. I've talked to a lot of officers who don't like to ask the information up front because they say, well, I'm gonna come up with all of these different types of reasons while I'm gonna fail the test because of my medical condition. And that's why I like to ask, do you have any medical conditions, any physical injuries that I need to know about before we do some simple tests? And if they say no, I'm going to go and I'm going to take them on their word because you're a nice human being and you're not going to lie to me roadside. Now, 6 months later, you come to court and you've got 52 out of 55 disease processes checked on this box. Did you lie to the officer on the road or did you lie to the court today? And I don't care what your answer was, but at the end of the day, you're a liar. And I don't know as far as being the district attorney, but wouldn't I have to bring in something to show that I was the diabetic, or can I just say that I'm the diabetic?
Eric, was that a question for Sarah?
Just for the prosecutors out there.
Oh, okay. Just
in the back of the head, you know, what is that defense lawyer bringing? What is that defendant bringing? You can bring your excuse, but the officer is going to bring his fact pattern. I'm just wondering what he's going to bring to the table to prove his side.
Okay, understood. Thank you. Another question in Q&A, Eric, if someone has resting nystagmus during a medical rule out, do you continue the field sobriety test or do you stop and call EMS?
So there's really not at this point enough information to call EMS. If you see resting nystagmus, you should stop depending on your level of training. Stop and move on, because if you see resting nystagmus, it could mean several different things. Ask the driver if they have any issues with the eyes. Put that stimulus, put your finger up in front of their face, have them focus, see if that resting nystagmus is there when they're looking ahead. What we need to do is have them look at the tip of your finger and the tip of your stimulus to see if it's consistent and it goes away. If you are trained at the SFST level, you can continue HGN, but you have to document that you went against the protocol. If you're a DRE, and I see some DREs in the room, if they have resting nystagmus, then continue with the test, because sometimes when you begin HGN, that resting nystagmus will, it may continue, it may go away. So it all depends on the level. I wouldn't call EMS just solely on resting nystagmus. You could, but I wouldn't call them solely on resting nystagmus.
Eric, thank you. And another question actually is coming from one of our team members. For those of us who are not law enforcement officers, but we have a concern about a loved one who may have a medical impairment that would affect their driving, how would we apply to get our loved ones reevaluated for a medical impairment?
And I looked over here, Sarah has uploaded the document into the chat box. So anyone can submit a driver's re-exam as a concerned citizen. In that link Sarah posted in the chat box.
Thank you, Eric, and thank you, Sarah. And so, folks, if you open up, if you're interested in that, open up the chat window, you'll see the link there that has been posted. All right. Well, I see no more questions in queue at the moment, so I'm going to go ahead and get into our closing. But as I'm talking, folks, if you've got any additional questions, just go ahead and raise your hand or submit them in Q&A. But let me share my screen here and get into some closing notes. So I do want to thank Eric again for a terrific presentation today. Thanks Sarah Garner and everyone who's joining us and for the questions that you submitted. Again, if you've got any additional questions in the last few minutes that we have here, feel free to go ahead and post them in Q&A or raise your hand and we'll call on you. And also, before you leave today's webinar, if you've got any suggestions on how we can improve the webinar series or future topics you'd like to learn about, go ahead and put those in Q&A as well. That would be helpful for us. Following today's webinar, as I mentioned at the beginning, you will receive an email with the recording link. So be sure to watch for that email in case you weren't able to attend all of today's presentation. That email is also going to include a link to request a webinar participation certificate. If you need a certificate for your training files, we're happy to provide you with one. So again, watch for that. Watch for the follow-up email. In the email, there will be a link. Click on that link and submit the certificate request, and our admin will email a PDF of the certificate for you that you can save to your computer or print out. Please note, if you happen to be watching the recording of this presentation right now, only attendees in the live webinar may attend or may receive a certificate. We're not able to award them for viewing the recording. We invite you to join us again for other traffic safety webinars planned for this series. We have several more throughout this summer. So if you'll visit the Traffic Safety Conference website at the link you see on your screen, it'll give you a list of all of our upcoming webinars. That's also where you'll find all the recordings of our previous webinars. At this same website, you'll also find information about the next North Carolina Traffic Safety Conference and Expo, which is going to be held next August in 2022 in Raleigh. We definitely hope you plan to attend that conference, and we also invite you to propose topics for presentation. So on the website, you'll find a link for presentation proposals to submit your ideas. So I'm taking a last look, Eric. I don't see any hands raised or any questions in Q&A. So with that, I want to thank everybody again for joining us for today's webinar. And until next time, goodbye for now.